Okay, so before we get into like our PowerPoint and lecture for the week, I wanted to kind of go over your guys' assignments and what you should be working on this week and then what we'll have next week for class, just so everybody's a little bit more prepared. So this week you guys have your OB Math 2 calculations assignment, and then you have your preeclampsia sim chart assignment that will be due also. Does anyone have any questions about those really quick? Okay. After reading your guys' discussion posts from last week, they were all like much, much better than the first one. So you guys did a really good job with discussion number two. I think you all answered the prompt very well and showed good nursing judgment, and it looked really good. So, and then for next week, we will have a quiz again at the beginning of class. Okay. So make sure you guys are getting into Zoom at or before 2 o'clock, because like today we start those right away. Okay. You'll also have your placenta previa assignment that'll be due in SimChart, and then your second set of NCLEX questions. And if you guys have any questions about those, feel free to reach out to me, and I should be able to help you with whatever you guys are needing clarified. Okay. Does anyone have any questions on the assignments for this week or next week? Okay. I also posted, I believe last night, a little follow-up about your exam. Since we finished exam one, if you guys have KGA scores that are below 78%, we should be scheduling a meeting. Any student or any of you guys that have lower scores in the class currently, I sent an email, I believe around Sunday night or Monday. So be on the lookout for that. And I can fit you in to meet with me sometime this week. Okay. It's important to get together so that I can kind of help show and point you in the direction of like things you should be studying, what you should be focusing on, extra things that you could be doing to work towards raising your grade, especially because we're going to be having exam two, and I don't want you guys to get too far behind that. It's impossible for you to catch up. Okay. So meeting now is going to benefit you rather than waiting until it's a little too late. Okay. So let me pull up my PowerPoint here and we're going to dive into the material. There's a lot to cover today. Okay, so this week we're going to be covering high risk antepartum care. Make sure this is working. Yep. Okay, so we're basically going to be covering anything that considers or can put moms into the category of being high risk. Okay, so during prenatal visits, we're going to be monitoring moms for a lot of different types of diseases that can occur during pregnancy or maybe occurring before pregnancy that put their pregnancies at a higher risk, and that we would need to be monitoring them much more thoroughly. Okay, so patients that have any of these things that I'm mentioning, we're going to be seeing them in the office much more frequently than we would be for a standard everyday prenatal care visit. Okay, so the first one I want to talk about is diabetes. This one is something you guys will encounter or see in labor and delivery quite frequently. It's pretty common. The biggest thing that we need to know about these patients is, are they pre-diabetic? So did this condition happen before they were even pregnant? Is this something they've been working or dealing with for longer? Or is this arising because of the pregnancy? We are going to be treating this differently depending on if it is pre-diabetic a pre-diabetic mom or a gestational diabetic mom. Okay, so on the side here, it says pre-gestational diabetes is a term that's given to a woman who's already had type 1 or type 2 prior to pregnancy. And then gestational would be a carbohydrate intolerance that develops during pregnancy. Okay, so you guys obviously have heard diabetes before. This is not your first nursing class, and diabetes is something that we ingrain pretty deep into your brains during nursing school. Okay, so you should know the difference between type 1 and type 2 diabetes. Type 1 is the absolute insulin deficiency at an abrupt onset of illness whenever a patient is younger. Okay, these are kids that people are being diagnosed when they're kids and are on insulin pretty much their entire life. Okay, and then type 2 is what is developing because of lifestyle choices, which results in a decreased insulin secretion and insulin resistance. Obviously, during pregnancy, women are experiencing a lot of metabolic changes. Okay. During normal pregnancy, there's going to be an adjustment in the maternal metabolism, which is going to allow for moms to have adequate nutrition for themselves and the developing fetus. Okay. There is going to be a difference between insulin amounts and insulin requirements in the first trimester versus the second trimester. And that's going to be really important to know. Like, are we telling moms to increase or decrease their insulin in first and second trimesters, and why? Okay, so you need to know the metabolic process of this diabetes in the gestational period. So one thing that I want you guys to know too is that glucose is transported through and across the placenta, which means that the glucose levels in the fetus are directly proportional to the maternal levels. So in the first trimester, you have the rising estrogen progesterone levels, which are influencing the pregnant woman's metabolic status, right? These hormones are fluctuating and stimulating the release of beta cells in the pancreas to increase insulin production. And this promotes increased peripheral use of glucose and decreased blood glucose. So women that have insulin-dependent diabetes are prone more to hypoglycemia during the first trimester. That's something we should be educating these patients on, especially pre-diabetics that already are on an insulin regimen. They need to be talking with their endocrinologist specifically, because while they're being seen for prenatal care, they should be having an endocrinologist that's following along with their management during this time period. It's very important that they have a specialist during their pregnancy. Okay, and they're going to be adjusting their insulin levels depending on the trimester, what their trend is. We should be educating them on checking their blood sugars at home, maintaining an adequate diet, making sure they're keeping really good track of that. Okay, this is different in the second and third trimester because those hormone changes and fluctuations, like your progesterone and estrogen, aren't increasing at as dramatic of a rate. So maternal insulin requirements gradually increase from approximately the 18th to 24th week of gestation to approximately the 36th week of gestation. So your insulin requirement may double or quadruple by the end of pregnancy. Okay, so in the first trimester, moms are more prone to hypoglycemia. So they're not going to be taking as much insulin. In the second trimester, their insulin demand is going to be greater. They're going to need to take more. Okay. So what kind of, besides like regulating your blood sugar and monitoring your diet, what other kind of education would we want to provide with these patients? What's some important things that these patients should be knowledgeable on? We should probably be telling them the signs and symptoms of hypoglycemia, right? When they should go and seek emergency medical treatment, when they need to contact their primary care provider, those kind of things. Because even if it is a mom who has had diabetes her entire life, this is going to be a totally different type of experience for them because you're not only educating them on normal pregnancy symptoms, right? You also have to educate them on the fact that, okay, yeah, your insulin reserves are going to be different in pregnancy. This is what hypoglycemia during pregnancy could look like. Okay. So some risks that are associated with diabetes in pregnancy, I have some listed out for you guys here. Macrosomia, which is a big baby. We got right here a picture of a really big macrosomic kid, okay? those babies that come out with the really big puffy cheeks, they look kind of swollen. That's a typical looking macrosomic baby. Um, Moms with diabetes are prone to gestational hypertension, which in turn can lead to preeclampsia. They're also at a high risk for polyhydramnios, which is an increased amount of amniotic fluid, right? And they are also at an increased risk for DKA, which you guys should know about DKA. That's pretty ingrained in your brains during nursing school. But they're at an increased risk for going into acidosis. So we need to be giving them a lot of education at the early stages of their pregnancy so that they're ready and know about these things. Oh, yep.
Is everybody hearing her?
I can hear her, Miss Brown.
I can as well.
I can too.
While we're paused from her lecture, Emily and Madeline A sent messages. Please turn your cameras on. Madeline, we're still waiting on you.
So sorry, I had to use the
Sorry, proceed.
Okay. So, as in part of our nursing judgment, we're going to be assessing these patients pretty thoroughly during their pregnancy. So, we need to know what their baselines are. Okay, that's going to be the most important thing so that we can see if their disease process is progressing, or it's increasing, or if it's being maintained and adequately treated. So. We need to know what their baseline renal function is. We're grabbing a urinalysis culture. We're going to get an A1C. Is this patient treating their diabetes correctly? Are they non-compliant with their insulin use? And if they are, we need to be educating them. We're telling them about the potential risk to mom and the potential risk to baby. Okay. Management is a huge part of this. So we're telling them, especially with diet. So typically these patients will be referred to a nutritional specialist or a counselor to help them manage their diabetes. Someone who's been used to controlling their diabetes outside of pregnancy may find that it's much harder to manage their diabetes during pregnancy. As far as exercise, we're encouraging them to get 30 to 60 minutes per day is encouraged, or to maintain whatever their normal activity level has been throughout their life, what they're used to doing. Their insulin, like I said in the first slide, their dose is going to vary during pregnancy, and they should be managed closely by their endocrinologist. Acceptable fasting levels are between 60 to 105. 1 hour post meal levels should be less than 140. Okay, so that's just kind of give them like where they should be aiming for to maintain their blood sugar. As far as like fetal surveillance during this pregnancy, the babies, of course, are going to be at a higher risk for neural tube defects, other things like congenital heart defects, that macrosomia, like we talked about, which can cause some other like respiratory issues when babies are born. So we want to be testing these infants and testing mom to monitor this baby very closely. The determination of birth date. So if a patient is insulin dependent, there's a chance that the OB provider is going to want the infant delivered earlier than 40 weeks. So that's what that kind of means. It's like if a patient is an uncontrolled diabetic, we might be inducing her at 37 weeks of gestation, depending on how big this baby is, how mom is doing during this pregnancy, how her pregnancy is progressing, and everything is going. And then also the mode of delivery is also going to be debated pretty much between the OB and the patient in question. So not saying that an uncontrolled diabetic is always going to have a C-section. That's not the case. But if we're inducing a mom earlier, and depending on like the fetal size and how at risk this fetus is, a C-section or an alternate type of delivery might be what we need to do. Okay, so gestational diabetes is different than a mom that had pre-existing type 1 or type 2 diabetes. They have fewer risks associated than women that have pre-existing diabetes. Risk factors that can increase a mom's chances of developing gestational diabetes would be a family history, obesity, if they already have hypertension, so a patient who has chronic hypertension, a maternal age that's greater than 25 years. Those are all risk factors that can increase their chances of developing gestational diabetes in pregnancy. The other thing that's important to note is that women who have gestational diabetes have a higher chance of developing type 2 diabetes later in life. Okay, so it doesn't always mean that they're going to develop type 2 diabetes, but they're at an increased risk for developing type 2 diabetes if they've had gestational diabetes in their pregnancies. So treatment and things that we're going to want to go over with these patients is very similar to what we would want to be teaching and educating our patients who have pre-existing diabetes. We're going to go over their diet. We'll refer them to a nutritional counselor if it's appropriate, encouraging them to maintain their exercise level or increase it if they haven't been, self-monitoring their blood sugars. So we're going to be giving them a glucometer and the test strips. Those are prescribed by the OB office, and they're going to point them into like how often they want their blood sugar monitored. So for some patients that might be just in the morning and at night or after meal times. For other patients, if they're at a higher risk or an increased risk of other underlying medical conditions, they might need to be monitoring their blood sugar pretty frequently just to make sure that they don't slip into anything dangerous like DKA or any of those abnormal conditions that we really want to avoid. Then let's see. Medications with gestational diabetics, they are not usually prescribed insulin, okay? If they're given anything, the most common medication that diabetic moms in pregnancy are going to be given is metformin, okay? Metformin is usually the go-to medication that we're giving our moms if they're gestational diabetics, okay? If they are prescribed insulin, there's a chance that they were already towards like type 2 diabetic before they were pregnant, okay? And then again, we're going to be monitoring these babies very, very closely because we don't want them to be getting too big. We want to make sure that the amount of amniotic fluid is remaining normal. So we're going to be getting that AFI testing done like we were talking about in I believe that's week 1. We went over all of those tests, or week 2. So all of those monitoring, all those prenatal visits and are going to be increased and have more frequency because we're going to want to keep a really close eye on these patients, okay? So the screening for gestational diabetes occurs typically between 24 and 28 weeks. The one that we usually use is the 2-step screening method. And this is a 1-hour glucose test. So what happens is a patient comes to the OB appointment. They typically will drink a 50-gram oral glucose solution, and then she'll have her blood sugar tested 1 hour following drinking that solution. The patient does not need to fast for this test. If she fails the 1-hour glucose test, she would need to repeat it and get a 3-hour glucose test, okay? So I have listed there that any result greater than 130 to 140 is a fail. And on the floor, if we see in the history in her prenatal visits that a mom has failed her 1-hour glucose test, most of the time their OBs are going to treat them as if they have failed and are pre-gestational diabetics. Okay. So sometimes some newborn providers are going to tell you, okay, let's go ahead and monitor the baby's blood sugar. Even if the mom passes the 3-hour glucose test, some of the newborn providers are going to still want to monitor that baby's blood sugar at delivery. Okay. So, with gestational diabetes and prediabetes, obviously we're going to cover newborns here later in the term. But that's why we want to know this about mom is because baby's blood sugar is directly affected by mom's blood sugar. So if the baby comes out and the mom has had uncontrolled blood sugars throughout her pregnancy, that baby is not going to be able to maintain the blood sugars for themselves as well, right? Because they will have had a lot of different sugar intake and their insulin and everything is going to be all out of whack. So we're going to want to know which babies we need to monitor closely and which should be okay. Okay. Because babies already have a harder time regulating their insulin levels and their blood sugar levels on their own. So that is one of the reasons why we're testing these moms so thoroughly. Does anyone have questions about pre-gestational or gestational diabetes before we move on to the next one?
No, ma'am.
Okay, let's keep on moving. Okay, so another important thing that we're monitoring moms for during pregnancy are thyroid disorders. Okay, so like we kind of mentioned whenever we were talking about the pathophysiological changes that moms go through during pregnancy, one of the big things happens with your thyroid. Okay, so in general, moms' thyroids are going to enlarge, their metabolisms are going to slow down a little bit, and your thyroid greatly impacts your metabolism. So we'll start with hyperthyroidism. It is more rare of a condition for women to experience in pregnancy. It occurs in 1 to 17 births in 1,000. Okay, so hypothyroidism in pregnancy is definitely more common. We see that a lot more frequently. The clinical manifestations of hyperthyroidism would be your heat intolerance, your diaphoresis, so your sweating, your fatigue, anxiety, emotional lability, and tachycardia. The hard thing about diagnosing thyroid disorders in pregnancy is a lot of these clinical manifestations are things that women will go through whenever they're pregnant in general. So that's why we rely pretty heavily on testing patients' TSH, T3s, and T4 levels so that we can see, okay, is what you're experiencing a thyroid related issue or is it just a side effect of your pregnancy? Hyperthyroidism, any type of thyroid disorder, comes with an increased risk of miscarriage, preterm birth, preeclampsia, and occasionally heart failure. The go-to treatment for hyperthyroidism is the propylthiouracil or the methimazole. And sometimes it requires surgery in really severe cases, but obviously, like anytime surgery is debated in pregnancy, we want to be really careful because we want to make sure that it's actually indicated and not something because we don't want to be exposing babies and moms to surgery unnecessarily, right? The other thing to mention is we have to be really careful with this medication treatment because these meds have a lot of side effects. Okay, so sometimes providers with hyperthyroidism in pregnancy, it's a lot harder to manage because most of the medication that we're giving for this disorder is not safe for use in pregnancy. So some side effects of these meds would be hepatic toxicity. And that one that I mentioned, that the one that has the really long name that is hard to say that I probably botched, but the propylthioryl acid, that can only be used in the first trimester due to potential side effects on the fetus. We obviously cannot do radioactive iodine in pregnancy because it's not only going to target mom's thyroid, it would target the thyroid of the developing fetus, right? And we don't want that. So management of hyperthyroidism in pregnancy is much trickier than management of and then management of hypo. All right. So that brings us here to hypothyroidism. So this is way more common, okay? It is not unheard of for women to develop hypothyroidism during pregnancy, okay? So clinical manifestations of this disorder are weight gain, lethargy, a decrease in exercise capacity, cold intolerance. So with hypothyroidism, their TSH is going to be elevated and their T4 is going to be low. So it's opposite in hyperthyroidism. In hyperthyroidism, their TSH is lower and their T4 is elevated. Okay, so I would know that definitely. And like most nursing tests and stuff, you guys shouldn't be able to know the regular, like the normal ranges. So with this disease process, they also have an increased risk of infertility, miscarriage, preeclampsia, placental abruption, preterm birth, stillbirth. The go-to treatment of hypothyroidism is levothyroxine. So one thing that's important to note, if a mom has hypothyroidism going into her pregnancy, she needs to try and have her thyroid levels under control before she gets pregnant. Otherwise, her risk of miscarriage increases greatly. That is one of the main things that you can see with hypothyroidism is early pregnancy, first term miscarriages. So making sure they have good follow up with an endocrinologist and they're managing their thyroid levels. They're getting those routine lab work drawn. And following all the rules associated with levothyroxine. So that medication, I don't know if you guys remember it from like pharm very well, but with levothyroxine, your patient needs to take it in the morning on an empty stomach, and they can't eat for about an hour after taking it. And if they are taking prenatal vitamins, those vitamins need to be taken at night. It shouldn't be taken anywhere near the levothyroxine because some of those vitamins will interfere with the absorption of Synthroid. Okay. So that's all stuff that as a nurse, we should be educating our patients on. Making sure they're aware of like those side effects, the things that they need to be doing and what they need to do for the medications. Alrighty, so moving on to cardiovascular disorders. So your textbook goes into much greater detail on the subsections of each cardiovascular deficit and abnormality. We're going to be talking more extensively on hypertensive disorders because these are much more common and something that you guys are going to see a lot more frequently. So obviously, as we know, the cardiovascular system is going to go through many changes during pregnancy. And if their body is not able to handle these changes, it could result in cardiac failure. A high fever is a major cause of cardiac decompensation during pregnancy. So if a mom has a fever, that's something we need to be telling them about. Like, hey, if you are sick, you have the flu, you have a huge high fever, you need to be following up with your OB so that we can monitor you and make sure everything is going okay during your pregnancy. Cardiovascular disorders affect usually only about 1 to 4% of pregnancies. And then with anything, a woman that has a higher risk, a woman who has a pre-existing cardiovascular issue is going to have a higher risk in pregnancy. Okay. So if you know a mom who already has been diagnosed with an arrhythmia or struggles with electrolyte imbalances like your potassium and it's throwing them into weird rhythms during their pregnancy, they're at a much higher risk of these things being exacerbated because of the metabolic changes and physiological changes that moms are experiencing during their pregnancies. Okay, so I have listed up there on the top a good page that has a really excellent table for you guys to reference whenever we're talking about these cardiovascular disorders. Immediately, if a mom is diagnosed with a cardiovascular disorder, we are determining them as a high risk pregnancy. Anything that has to do with the heart or cardiovascular wise is going to affect a lot of other bodily systems. So we need to be watching and following these moms very, very carefully, right? During their pregnancy, before, during, and after pregnancy, just to make sure that there's no nothing else that we need to change or anything that they need to be doing for follow-up care. Okay. So for antepartum and postpartum, we want to be educating these patients to minimize their stress on the heart. We're teaching them the signs and symptoms of decompensation, which has in that box, the box 11.3, which would be like dyspnea, tachycardia, edema. We're looking for signs and symptoms of congenital heart failure. So is the mom having that generalized edema, their jugular vein distension, any dyspnea on exertion, or just dyspnea at rest? If they're experiencing palpitations or they're having that wet cough, we're telling them, okay, you need to go into the ER, you need to be seen immediately, right? We're educating them on signs and symptoms of VTE, and we're telling them to avoid straining and constipation. So these are patients 100% that we're going to be prescribing them stool softeners, both before, during, and after their pregnancy. And why is that?
Because don't your heart.
Sorry, what was that?
Well, you have the bowel movement, don't your heart?
We don't want them to vagal, right? When
Or
they're
go to drop or something.
So we don't want them to vagal, because whenever you're straining for a bowel movement, you run the risk of vagaling. That pressure on your vagal nerve can cause patients to pass out. And in patients with cardiovascular disorders, we do not want them passing out. We do not want them vagaling. We don't want to throw their heart into an abnormal rhythm, right? So educating them on stool softeners and foods that are going to make their bowels softer. So increasing their hydration, making sure they're having adequate water intake. That's very important for these kind of patients, right? We're having them, like any patient that has cardio issues, we're having them do daily weights, okay? And this is mostly just to monitor for swelling, edema, water displacement, that kind of stuff. So we're telling them to weigh themselves at the exact same time every day in no clothing or whatever they have been weighing themselves in before, okay? These patients should also be limiting activity. This is not the patient that we want their heart rate to get extremely, extremely high. So if they're used to doing light exercise, that's sometimes okay, but it needs to be cleared by their OB/GYN. These are patients that you might be educating them on, like, we're going to have complete pelvic rest during your pregnancy, no sex, nothing that is going to be like increasing your heart rate or anything that is going to be exerting. So these are patients we need to definitely be giving them education on. During their pregnancy, we're going to help them by managing any discomfort, positioning them to help support their cardiac function, and then open glottis pushing. I believe I have a video to show you guys on that. It's basically just having moms push without bearing down and vagaling as much as they would if they were doing closed glottis pushing. So I should be able to find a video. If I don't have it in this PowerPoint, I'll attach it to the week 5 announcement so that you guys can see what the difference is between open and closed glottis pushing. Okay. So our interventions for these moms in antepartum, we're going to make sure that their infections, if they have an infection, is being treated very quickly. We're going to be monitoring for iron deficiency anemia, because that is something that is at an increased risk for with cardiovascular disorders, and something we really want to avoid. And then also the nutrition counseling. These patients, and as well as with diabetic patients, these patients, we need to make sure that they're restricting their sodium intake, any type of diet that we're putting like typical cardiac patients on in their pregnancy. We're going to need to make sure that we're monitoring any type of restriction that they need to have to make sure that their disease process doesn't increase. During pregnancy, we're monitoring these patients extremely closely. We might have to adjust our typical pregnancy and labor education to format what is going on with this patient and what they're experiencing in their life. And then postpartum, we're monitoring for cardiac decompensation, especially in that first 24 to 48 hours after birth. And then obviously these are patients that we do not want to have hemorrhage. We do not want these patients bleeding, okay? If they are hemorrhaging with a cardiovascular disorder, they are at an increased risk for worsening that condition. And these are moms that sometimes will end up in ICUs, depending on how bad the hemorrhage is and what's going on with their heart. So kind of segueing into anemia. This is a very, very common disorder of pregnancy. So about 20 to 50% of pregnancies have moms are diagnosed with some form of anemia. So iron anemia is the most common form. It's diagnosed by a serum ferritin level. So it's diagnosed with a lower serum ferritin level, so under 12 micrograms, along with a low hemoglobin. Okay. Iron deficiency anemia, we're going to be increasing moms to intake their iron, right? So whether that's a supplement, whether that's a infusions, if they have to get infusions at the hospital, but mostly it's supplementation to help treat this iron deficiency anemia. And that supplementation should be happening months before they give birth, because we want to build up those hemoglobin levels because we are anticipating them to drop in some form or fashion after they deliver. The next one is folic acid deficiency. So this one is why we have moms take prenatal vitamins that are high in folic acid. So folic acid is essential for spinal cord development, which is something we kind of talked about whenever we were talking about neural tube disorders. So increasing mom's B12 folic acid intake is very important during pregnancy, especially in their first trimester, which is when a lot of those things are being formed, right? So then we also have sickle cell, which is the sickling of the red blood cells. This is more common in African American population. The one thing that we want to educate these patients on is they're at an increased risk of sickle cell crisis whenever they are pregnant. Okay, so sickle cell crisis, have you guys learned about this yet? Okay, so sickle cell crisis occurs whenever that blood, I have a picture of the red blood cells up here where they will take on this sickling appearance. Okay, and sickle cell crisis can happen usually if like the individual is exposed to really cold temperatures. They're around things that can exacerbate their disease process, which is usually like a change in temperature. So we're educating these patients on like if it's going to get a lot colder, we need to be wearing adequate layers. If they have like underlying things like asthma or any other type of medical conditions, if those flare up, they're at an increased risk of falling into sickle cell crisis. Okay, so educating these patients on making sure you're taking really good care of yourself because we don't want you falling into a sickle cell. If they are in sickle cell crisis, it's extremely, extremely painful. These patients will be in the hospital for a week to multiple weeks at a time, getting pain medication, getting red blood cell transfusions, all the things to try and get them out of that crisis. Okay. So here I have listed the treatment for a sickle cell crisis and for sickle cell anemia, which would be blood transfusions. You're avoiding those triggers like the cold if they have any asthma, underlying medical conditions, and then folic acid supplementation. Okay. The last one we have to talk about is thalassemia. And this is an insufficient amount of hemoglobin is produced to fill red blood cells. So it's a hereditary disorder, and these patients might also require blood transfusions during their pregnancy. Okay. Moving on to asthma. So asthma is a chronic inflammatory disorder of the tracheobronchial airways. It's triggered by allergens and other irritants. Like I said, the weather changing. Up here in Ohio, it's getting kind of colder. The weather's turning like low 40s. So people with asthma are definitely going to be feeling that a little bit more. With asthma and pregnancy, it really is variant based on the patient. Okay. So if the effect of pregnancy on asthma is unpredictable. The goal during pregnancy is to prevent asthma attacks. Okay. Because anytime a mom is deprived of oxygen, guess who else is deprived of oxygen? the baby, right? So we do not want mom to be having an asthma attack whenever she is pregnant. So we're educating patients on avoiding triggers and allergens, telling them and educating them on the correct way to use their inhalers, which is something you guys should have gone over in pharmacology. So giving them good education on what medication to use first, how to use an inhaler, making sure they know how to use the inhaler, making sure their inhalers aren't expired, that they're getting refills on them periodically and changing out their inhaler to make sure that the medication is still good and not an expired med. And then making sure that they're maintaining a medication regimen that's prescribed by their physician. Okay. So over there, I have a picture of an inhaler and then how to prevent airborne allergens. Okay. So like if a pregnant woman is an asthmatic, she should avoid like vacuuming and dusting because kicking up all that dust could exacerbate her disease process. And we really want to avoid that. Okay. So just those are some things that you guys can note. All right. So a lot of changes happen to a pregnant woman and her skin. Okay. Sometimes women will just get rashes during pregnancy and their OBGYNs will look at it and they'll just be like, yeah, that's okay. That can happen. That's normal. And it'll be like big bumps or something, like super weird. Those kinds of things can happen during pregnancy pretty often. But there are some ones that I wanted to go into a little bit more detail on. So the first one is this pruritus gravidarum. This is generalized itching without the presence of a rash. So moms that are at an increased risk for this disorder would be multiple gestation. So a mom who's carrying twins, moms who have undergone fertility treatment. So this is an IVF baby. If a mom has diabetes or this is her first pregnancy, she can be at an increased risk for this. Treatment of this is pretty low key, mostly just lotion and oral antihistamines. Okay, so it's just that generalized itching. Moms usually don't have rashes with this. Okay. The next one is polymorphic eruption of pregnancy, and this occurs usually in primates, so first-time moms, during their third trimester. For some reason, and they did find like a correlation between moms who are carrying boys. So if a mom's pregnant with a boy, she has a higher chance of having this condition. The treatment is antipyretic topical meds, a topical steroid, or an oral antihistamine. And then the last one we want to talk about, which is probably the most important one that I want you guys to focus on, is your intrahepatic cholestasis of pregnancy. So this is cholestasis of pregnancy. This is a liver disease in pregnancy. And what it does is it causes moms to have itching in the third trimester, and it typically occurs on their palms and the soles of their feet, and it is terrible. Like moms will come in with this and they will be like, I feel like I'm going to itch off my skin. Like they will come and sit down in the bed and they will just nonstop be scratching at their palms and at their feet. I had a mom one time who came in with this. She was an Amish lady and had not had any prenatal care, and her entire palm was just completely scraped raw. Like she had just scratched off like most of the skin on her hands. So it can get pretty intense. This is caused by an elevated serum bile acids and liver function. Well, no, you can diagnose it based on elevated serum bile acids and liver function tests, okay? Because it's going to be a liver disease. So all of those things are going to be elevated or skewed. The treatment is this really hard word to say, the ursodeoxycholic acid, which they will be on this up until they deliver. This is a medication that sometimes their providers will even encourage them to be taking while they're in labor. And that is simply because they want to minimize the disease process as best that they can, especially during labor. And then we are also going to be monitoring this baby closely because with any type of maternal disease, we want to make sure the baby is not having any side effects from it. Okay. So the other important thing to mention with cholate, so I'm having to see my screen a little bit better. There are a couple poor fetal outcomes that can be associated with this. So, like, usually if a mom is diagnosed with cholestasis of pregnancy, we are going to be inducing her around like 37, 38 weeks. Like, this is not a mom that we're letting her go full term because of the just the way that this disease process works and its effect on the placenta and on the baby and fetal circulation. We don't want this mom going full term. So she's going to have an earlier baby. And you also run the risk of having stillbirth. Okay. So that mom who came in, who was an Amish patient who had no prenatal care, that was one of the first things that we wanted to make sure. We put the baby on the monitor immediately because she hadn't been seen in the office. We have no idea what is going on with this kid. And she comes in with cholestasis, pretty severe at that point. And she was already, I think, like 38 or 39 weeks. So she ended up having a C-section that night because it was so progressed and had already reached that point. Okay. So whenever we're talking about high risk moms, okay, a big thing we need to talk about is substance use disorder. If a patient comes in, which not every patient is going to tell you, yes, I used cocaine throughout my entire pregnancy. Like, not every patient is going to be forthcoming about that information because they don't want the baby taken away. They don't want that to be known knowledge. So we kind of have to use our assessment skills and we need to identify moms that are at risk for substance use disorder and moms who potentially could be using substances during their pregnancy. Okay. Some warning signs would be moms who have late or no prenatal care. They're non-compliant to their treatment. They have poor nutritional intake, or moms that already have cases open with like CPS, or have had social work consulted, or have had things come up with legal disputes, like any type of thing like that, we need to be monitoring. Typically, if it's a mom that has a CPS case that's already open with another child, we have knowledge on that and we have the access to see what was going on with that pregnancy to kind of determine like, okay, well, what should we be doing to monitor this one? In prenatal visits, we screen every patient for the prevalence of drug use. So, and that happens pretty early in the pregnancy. Like, I think it's in the first trimester, they're screening you, or early in the second trimester, they're screening you for drug use or any presence of any type of drugs. Usually it goes along with like the STD, STI testing. Commonly seen substances I have listed here. So tobacco, alcohol, marijuana, opioids, cocaine, and methamphetamines. So tobacco is one that we see a lot. Moms who smoke. Another one that's a lot more common now in this day and age would be like vapes, e-cigarettes, just any type of vaping product. Complications that are associated with these would be an ectopic pregnancy, placenta previa, placental abruption, preterm rupture of membranes, IUGR, which is your intrauterine growth restriction when babies just aren't growing the way they should be, and then like low birth weight babies. So in my experience, moms who smoke pretty heavily, I see a lot of moms come in and they have really, really small babies, or even like their umbilical cords are really little. Placentas could be a little bit smaller than normal, just because of the way the nicotine affects the pregnancy and the growing and developing fetus. With alcohol consumption, you have an increased risk of birth defects. So we talk about that a little bit whenever we talk about the newborn stuff later in this term. But we're talking about babies that could have some congenital abnormalities and defects if moms are drinking heavily and frequently during their pregnancies. With marijuana, there really hasn't been too much evidence-based research on that yet. The biggest thing that they find with marijuana use is that intrauterine growth restriction. Okay. I know there's a lot of studies that are taking place currently. I was looking into it a little bit when I was writing this PowerPoint. So it's just not as heavily researched as the other ones. With opioid use, your complications are IUGR, placental abruption, your intrauterine. So a baby could have meconium, a bowel movement when they're in utero, which is a high risk for the baby during delivery because they can swallow that meconium and it causes respiratory issues, preterm labor, and then in worst case scenarios, fetal death. Okay. The biggest thing with opioids is that mech fluid and the placental abruption that I've seen in the past. And the other big thing we need to know is that infants will withdraw from some of these things, right? So opioids is a huge one. Babies are going to withdraw. We'll talk about the signs and symptoms of withdrawal in an infant whenever we talk about infant newborn assessment. Cocaine, the biggest one I want you guys to know is they are at a huge risk for placental abruption. That is the biggest thing you're seeing with a cocaine user. We had a patient who came in who the baby ended up passing because she came in and had admitted to cocaine use earlier that day and just had this increased abdominal pain and just had no idea where it was coming from. So she finally came in, and by the time she came in, she was bleeding pretty heavily. Her blood pressure was super low. We ended up having to transfer her and the baby after immediate delivery. We did a stop and drop C-section on her. So a placental abruption is the biggest thing you're going to see with cocaine use. And then with methamphetamines, babies are at a high risk for microcephaly, again, placental abruption, and then congenital malformations of brain and heart. Okay. Excuse me. So one thing I wanted to include, because sometimes, like I said, these patients aren't going to be forthcoming and be like, yeah, I used cocaine 2 days ago or whatever. Screen them with the 4 Ps. Parents, partner, past, and pregnancy. Okay. Starting with parents, did either of your parents have problems with drugs or alcohol? Right? When you're taking their intake, they're taking their history forms down. Is your parent an alcoholic? If they are what is your drinking pattern like? What do you usually, are you a social drinker? Do you drink during the pregnancy? It kind of just segues into the questions that we need to ask. Partner, does your partner have a problem with drugs or alcohol? Are they around this stuff a lot? Like, are they being exposed to different substances? Have they had any beer, wine, liquor, or used drugs in the past, heavily or within a different pregnancy? And then in the months leading up to pregnancy, how many cigarettes did you smoke? And how much did you drink? Those are actually questions that we used to ask them, like on the birth certificate when the moms were filling out birth certificates. I'm not sure if they're still on them now. I think we just changed ours at our hospital, but that was part of the typical screening process. Okay. So as a nurse, you might need to come up with like creative ways of asking your patients about this stuff. If you just straightforward ask them like, hey, is this what you do? Not everybody is going to be forthcoming. So kind of getting an idea of their background, their social history, is going to help you with identifying these kinds of things. For our interventions, as nurses, we need to educate the patients on side effects for them and baby, okay? And unfortunately, I wish I could tell you that by educating the patient, you're going to completely change their habits and the way that they're going to handle the rest of their pregnancy. But unfortunately, that doesn't always happen that way. So, but we still need to tell them what they're looking at. Obviously, we're telling them that abstaining from any type of substance during pregnancy is the best course of treatment. So unless they're heavy opioid users, right? If they're heavy opioid users, we're worried about moms withdrawing. Same with alcohol use, okay? Withdrawing from opioids and alcohol is a very dangerous process for people who are used to taking very high amounts for long periods of time. So we need to get them in on a program, get them into a facility that's going to be able to monitor them in the pregnancy if they are wanting to stop. Nicotine replacement therapy needs to be used cautiously because sometimes the gum or the patches, sometimes they can have adverse effects on the developing fetus. So we need to be watching that, and it's really up to the OB/GYN what is contraindicated and what's needed at that time. Any patient experiencing withdrawal must be monitored carefully in the hospital. We're also mandatory reporters, okay? So if you have a patient who admits to drug use, we have to report that. We also need to get a urine and a stool sample from the newborn to test the baby whenever they're born for any presence of drugs in the stool or the meconium. If they test positive, that's something we also report to CPS, and then they get involved immediately. Okay. What are some other things that you guys can think of that we should be watching for or being careful with these patients? Like if you know a patient has been using substances? What's some things that we're going to want to do or bear in mind?
Like you said, monitoring vital signs, just also make sure they didn't bring any contraband in. And if they do have any withdrawals, just monitoring them as well as the.
Yeah, that's excellent. Definitely. And that's sometimes hard whenever like,
I would
oh, go ahead.
no, I was gonna say behavior
What was that? Sorry.
aggressive or behavioral monitoring to make sure they're not aggressive or like harming themselves or
Definitely. Yeah. Yeah, that's really good. Anyone else have an idea? Yeah, those ones you guys mentioned were really good. Especially with the behavioral stuff, right? The other thing too to note is if you have a patient who comes from like a jail, like who's being furloughed from prison for like prenatal care, how is your hospital managing that, right? What's the policy? Do they have a police officer that's with them 24/7? If you're at a smaller facility, typically what happens is that the jail will sign over to the hospital, and then that patient is the hospital's responsibility. They sometimes won't have a cop that stays with them from the county. Usually the smaller facility has to provide police enforcement to monitor that patient. So like one time I had a patient who was a known meth user who was being furloughed from prison, and she ended up, not on my shift, I wasn't there, but she ended up running out of the hospital with her IV in, and she had on our wireless monitors, which are like $10,000. Like they're very expensive. And she ended up coming back to the hospital, but she went and got picked up by somebody and did drugs and came back. And it was a whole thing. That nurse had to go and talk. She had a disposition for that patient because the hospital was going to press charges and she stole some medical equipment. So you got to be careful whenever you have patients, especially under observation, or patients that are being watched for like mental health or any type of behavioral disorder. Just keep in mind that yes, while we're monitoring their baby, we also need to take into consideration their background and their social history as well too. All right. So we're going to talk briefly about autoimmune collagen vascular disease. So the biggest ones here would be like your systemic sclerosis, your antiphospholipid syndrome, rheumatoid arthritis, myasthenia gravis, and then your lupus. So the ones I really wanted to talk about was your myasthenia gravis and then lupus. So starting with myasthenia gravis, that affects your motor function. It's muscle weakness that may affect the ability to push, right? So that's something like if you know about this disease process, we're kind of trying to format, okay, what does this look like for the pregnant woman? Like a patient that has decreased ability of motor function is going to have a hard time delivering a baby and pushing a baby vaginally. Okay. So these are kind of patients that are going to be followed more at like your level 3 trauma OB centers. Like they're going to be higher risk. They're usually not at level 1 smaller LDRP facilities. So in myasthenia gravis patients, giving them MAG is contraindicated because it's going to impair the already slow muscle nerves, and it's going to impair muscle, like the connections between muscle fibers and nerves. So we're going to talk about MAG here shortly, but that medication will slow down your muscle function. So with these patients, it puts them at a very dangerous level. Okay, so we don't want to be doing that. Lupus patients, lupus is a multi-system inflammatory disease. And with this patient, they have increased risks of IUGR, preterm birth, stillbirth, miscarriage, and preeclampsia. Okay, so those are the two that I want you guys really to know about is the myasthenia gravis and then the lupus. Okay, so why don't we go ahead and take our break since we're kind of entering into a new like chapter here. So come back in 15 minutes. So 3:30 Eastern time, that would be 2:30 Central, 12:30 Pacific. Okay, so I'll see you guys in 15 minutes. Hi.
Hi.
Oh, hold on. Should I stop recording or pause it? I can pause it. Okay, so before we jump back in, I had a really good question that was asked, which I just saw. Um, whenever we were lecturing earlier. So I'm going to address that really quick because it actually is a really good question. So the question was that whenever you guys learned about diabetes, their symptoms are controlled if it's well managed. So is that the case during pregnancy? Um, so like if a mom maintains really good blood sugar, does that affect the baby? And the risk. So kind of that, which that is a good question. So whenever you're talking about any type of these like conditions, if it's well controlled, the risk of having any type of abnormal condition or any type of adverse effect is going to be like a lot smaller. Okay. So like if a mom is maintaining her blood sugar really well, she is not going to, the baby has a much lower chance of having like being macrosomic, or having like polyhydramnios. It doesn't mean it won't happen, but it just means that like their chances of that happening are significantly lower just because they're managing their disease process way better. Does that make sense? And that kind of goes for like really mostly anything. So, like with the thyroid stuff, if a mom's thyroid is well managed, her risk of miscarrying is significantly lower. Um, so, just with any type of thing that we're looking at with high risk, we want to make sure that it's being well managed because if it's well maintained, then we're not as worried about an abnormal outcome. Okay. And then before I start lecturing, Jamia, if you'll just come back in your screen, same with you, January, we're going to get started here. And then Tamikia, I'll need you. Oh, I see you. Never mind. Sorry. I couldn't see you for a second. All right. So moving on with the high risk perinatal care. These are going to be conditions that moms are going to be developing during pregnancy, which is a little bit different than what we've been talking about because the things we've been talking about are medical conditions that could have happened before the mom was pregnant too. Okay. These ones are more specific to pregnancy itself. So we're going to talk about them in a little bit more detail, which is why I took a break earlier because this is going to be a little bit more pertinent to labor and delivery. Okay. So the biggest one that we're going to talk about is hypertension in pregnancy. We're going to talk about chronic hypertension, gestational hypertension, preeclampsia with or without severe features, HELLP syndrome, and then eclampsia. Okay, those are the biggest ones we're going to go over. So gestational hypertension is defined as a systolic blood pressure over 140 and then a diastolic blood pressure greater than 90. And typically providers want to see that twice in a row, not just like a random, they just walked into the office, this was their blood pressure, and then they sat for 10 minutes and it was 120 over 85. They're going to want to see it pretty sustained before they give you a diagnosis of gestational hypertension. So I have here that it must be recorded on 2 occasions at least 4 hours apart after 20 weeks gestation in a woman with a previously normal blood pressure. This disease process usually resolves itself after birth. Okay. So gestational hypertension, we're talking about specifically when a mother develops high blood pressure during pregnancy. This is different from chronic hypertension because hypertension that is chronic can be before pregnancy and it's diagnosed before 20 weeks of gestation. Gestational hypertension can be diagnosed as chronic if it persists into the postpartum period. So if a mom has really elevated blood pressures during her pregnancy and then during her labor, and then it's sustained afterwards, like she's going home on medication, and then she keeps getting follow-up visits and her blood pressure remains high, then she can be diagnosed with chronic hypertension. Okay. The biggest one that we're going to talk about, one of the biggest ones we're going to talk about here is preeclampsia. Preeclampsia is a OB emergency, a medical emergency. It is something that we want to take very, very seriously as labor and delivery nurses because it can go south very, very quick. Okay. So in preeclampsia, the placenta is the root cause. Okay. The placenta is what's causing this mom's blood pressure to increase, what's causing her labs to become abnormal, causing her dizziness and epigastric pain, all the symptoms that can be associated with preeclampsia. That placenta is the root cause of these problems. So how do we solve preeclampsia? How do we treat preeclampsia? We deliver the baby, we deliver that placenta. Okay. Preeclampsia is a progressive disorder. So it's currently thought that the pathologic changes that occur in the women with preeclampsia are caused by disruptions in placental perfusion and then cell dysfunction. So these changes can develop early in pregnancy, long before a mom has signs and symptoms of preeclampsia. And you guys don't need to necessarily know the entire medical process, pathophysiological process of preeclampsia, but I'm going to go over it for you. I don't have it written on the slides here, but I will have this recording posted. So normally in pregnancy, the spiral arteries in the uterus widen because of the thick-walled muscular vessels, and they become thinner to sac-like vessels, allowing them to handle an increased blood volume of pregnancy. So because this vascular remodeling does not occur, or only partially develops in women with preeclampsia, that is what causes decreased placental perfusion and hypoxia. So poor placental perfusion as a result of vasospasm and reduced plasma volume is what is going to cause an increase in your blood pressure. Okay, so those changing of the vascularity and the vascular structures in the placenta ultimately is causing that blood pressure and that mom to rise, which is why we say for preeclampsia that the placenta is the root cause. It's causing all those vessel changes and all of those changes in the mom. So we need to be delivering that baby and delivering that placenta to reverse the preeclampsia. Okay. We do not have currently a test like when we talk about like genetic testing, carrier testing, we do not have a test that's going to tell you if a mom's going to become preeclamptic. Okay. That's not something that we have developed yet in medicine. But we do know some risk factors. So a mom who's never been pregnant before, this is her first pregnancy. If she has a twins or multiple gestation, she's had preeclampsia with a different pregnancy, that will increase a mom's risk. If she has chronic hypertension, if she was a pregestational diabetic, thrombophilia, she's obese, a maternal age greater than 35, and if she has underlying kidney disease. Okay. All of those things can contribute to a mom's risk for having preeclampsia. Associated problems. So with this disease, you're seeing increased blood pressure, reduced kidney perfusion, tissue edema. They're going to be swelling really bad in their lower extremities, most likely, their feet. They're going to have headaches. Their reflexes, they're going to have hyperreflexia. They'll have positive ankle clonus, which is a test that we're going to be doing when we're assessing preeclamptic moms, especially if they're given magnesium, which we'll talk about here in a little bit. And then in worst case scenario, this can develop to be, and moms can have seizures. That's why this is such a big deal, okay? Because moms, if we let this go untreated for a long time, they run the risk of seizing. So this little picture over here shows the background, your risk factors, signs and symptoms, okay? Preeclampsia also can develop like very, very quickly. Like you might see a mom in the office 2 days ago, and she comes into the hospital and she's like, I just haven't been feeling great. My head's been hurting. My vision's been kind of weird. I've been swelling really bad. I haven't been peeing as much. And that are all things that in your head should be red flags. Okay. Because it can develop like within even hours. Like I've had patients that I've been monitoring when they're laboring and they're all of a sudden their blood pressures are spiking. And it's not because of pain. It's because they're developing preeclampsia. So some things that we can do, if moms have a history of hypertension, we can put them on low dose aspirin. Assessment wise, we need to be getting accurate blood pressures, telling them don't cross your legs, have them sitting up, monitoring their edema. We're using our charting system to score if it's pitting edema. We need to be charting that. Deep tendon reflexes are some things that we're going to be monitoring really closely with these patients too, because we mentioned with preeclamptic patients, they have that hyperreflexia. If we're seeing that and they have all those other things, then we need to be starting treatment immediately. Clonus, presence of any protein in the urine, and then neurological changes. So if mom is not alert and oriented, that is definitely something we want to make note of. If she's starting to lose consciousness, if she does seize, those are all things that we need to be paying attention to. So like I said, there have been many studies conducted on various vitamins and other supplements that medical professionals were hoping that would lower the chances of a woman developing preeclampsia. And the only medication proven to be effective is the low dose aspirin. Okay. We usually don't start the moms on low dose aspirin until about 12 to 28 weeks gestation in women with high risk factors. Like I said, there's not really any biomarkers or screening tools available to identify women who will develop a preeclampsia. And then proteinuria. So like in a 24-hour specimen, what you guys are going to need to know is like what is an elevated amount of protein or a PC ratio. So when we're getting a urinalysis on women that have a history of preeclampsia, we're looking for a PC ratio, their protein creatinine ratio. Proteinuria is defined as a concentration at or greater than 300 milligrams or a PC ratio greater than 0.3. Okay, so they also kind of stage proteinuria. So a mom who comes in who has a proteinuria of 0.3, her PCA ratio is at 0.3, but she doesn't have any elevated blood pressures. She doesn't have any other signs and symptoms. This is something that the provider might just monitor. It doesn't necessarily mean, yeah, you're preeclamptic. Usually they want or diagnose based on a mom having multiple of the signs and symptoms. But say a mom comes in and her PC ratio is 0.6. That is an elevated PC ratio, and she's having some headaches and her blood pressures are borderline. We're probably going to treat her for preeclampsia because of that lab value. Okay. So you need to be looking at this patient's whole picture. You can't just be looking at their labs because that might not tell you everything you need to know, right? You also can't just rely on labs because I had a patient whose blood pressures were like 160s over 120s, and I got a PC ratio and it was normal. But we're not going to just be like, okay, yeah, go home, see you later. We're going to be treating that patient too. So HELP syndrome is a variant of preeclampsia. It's diagnosed by specific laboratory values. That is what the HELPS, that mnemonic kind of spells out. I have it over here in this little picture. It can occur in women without hypertension or proteinuria. So HELP syndrome is not always dependent on if they have high blood pressures or if they have protein in their urine. With these patients, you have an increased risk of maternal death, pulmonary edema, acute renal failure, DIC, placental abruption, liver failure, sepsis, and stroke. Okay. So it's defined with hemolysis, elevated liver enzymes, and a very low platelet count. Okay. So whenever patients come in that we're suspecting have any type of blood pressure issues, as their nurse, your patient just got to the room and you're asked them, okay, have you had any high blood pressures during your pregnancy? And they answer yes. What are some things that you're going to anticipate the doctor ordering?
Routine vital signs.
Mm-hmm.
Medication, a blood pressure medication.
Yep.
They're able to.
Yeah. Before we do any meds too, like what are they going to order as far as like labs? Like what were we thinking they're going to want?
The liver enzymes.
Mm-hmm. And that's usually in what lab do we get for a ALT, AST value? We're going to want a CMP, your complete metabolic panel. You're also going to anticipate your provider ordering a urinalysis, which in your urinalysis, that's going to be that PC ratio we just talked about. Okay. You also are going to anticipate, usually providers are ordering a CBC, right? That's pretty standard with any patient, and a uric acid. Okay. So those are the big ones that we're looking at whenever we're talking about what are lab values that providers are going to want on patients with hypertension issues. So whenever we talk about preeclampsia, one of the things that in OB that we talk about a lot are preeclampsia or gestational hypertension, and then preeclampsia without severe features versus preeclampsia with severe features. And this is kind of important to know as far as just for like treatment purposes, okay? So without preeclampsia without severe features, the goal of treatment is to progress the pregnancy as long as the fetus will allow. And they most likely will schedule induction around 37 weeks or the following week if the infant is tolerating pregnancy and everything looks fine. Okay. Management of patients with that have preeclampsia without severe features could be mainly at home. Okay. So these are the patients that have high blood pressures, but they don't have the swelling, the headaches, the dizziness, the blurred vision. So they might be prescribed labetalol 100 milligrams twice a day and monitoring your blood pressure at home. Call in if your blood pressure is over your high number is over 140 if your low number is over 90. That's a pretty typical thing that OBs will do. Okay, so that's management for moms that have preeclampsia without severe features. They should be educated very extensively on signs and symptoms of high blood pressure. You want to tell them about, like, if you're having dizziness, if you have blurred vision, you have increased swelling, decreased fetal movement, anything like that, you need to come into the hospital. Okay. Gestational hypertension and preeclampsia with severe features, that is going to be managed in hospital. These patients are going to need medication that they can't take at home. It's going to be most likely magnesium. Okay. And I kind of put here in very aggressive bold pink letters that we need to assess our patients, not our monitor, right? That's huge as a nurse. Like, you could have a patient whose blood pressure looks perfectly normal, but they're telling you, like, I had a period of time at home where I passed out and I don't know what happened. I don't remember anything. And I have all these other things that are happening. I have swelling. I have this. So it's like, we need to be doing some more testing. We need to see what's going on, right? Same thing with, like, if your blood pressures are astronomically high, but your lab values are just dandy, we need to make sure we know the importance of how severe what blood pressures can do. Okay. So management in your hospitalized patient. So this is your patient that has preeclampsia with severe features. It depends on the gestational age. Anyone earlier than 35 weeks should be at a facility with high risk maternal and fetal care available. Okay. Because that is a preterm baby. So the management is going to be a lot different in that patient than it's going to be in a patient who's full term, right? A really important thing that I want to talk about as far as, like, delivering any patient that's earlier than 35 weeks, we should be administering corticosteroids to the mom, and that is to help with fetal lung development. Okay. So with moms too, that come in with preeclampsia, or we know that they're going to be having a preterm infant, we want to try and delay their birth until we can give them the adequate amount of steroids to make sure that we give this baby what we can before they're delivered. Okay. So the go-to treatment is betamethasone or dexamethasone. Betamethasone is administered in 2 different doses, 12 hours apart, and each dose is a 6 milligram IM injection. Okay. That is usually what you see. I've not really ever given dexamethasone. I think they really do that if the patient has, like, an allergy or something, or has had an adverse effect to it before. But this is a really important thing whenever we're talking about fetal development and lung development, is giving them that corticosteroid for fetal lung maturity. The other thing that they will do, which this is getting kind of ahead, we're going to talk about this more next week, is they will administer magnesium to these patients, because mag helps with fetal neurological development, not only with the things that we need it for with moms with high blood pressure, but magnesium will help with your fetal brain development. Okay. So sometimes they're going to put these moms on mag when they're early, not just for high blood pressure, but to help this baby. Okay. So we're also going to obviously be monitoring these patients continuously until their symptoms subside and patient is stable, or until the delivery of the infant. If delivery is imminent or clinical symptoms have reached dangerous levels, we are going to be managing these patients differently. Okay. So really, like, your triage and your admission is going to be very important in these types of patients, because these providers are going to want to know, like, what are they dealing with? What are they looking at? Okay. So this kind of transitions into our management of the laboring preeclamptic patient. So your patient comes in, she's 35 weeks. We put her on the monitor. She's contracting every 3 minutes. Her water broke. We did an actum prom. We know it's definitely ruptured. This baby is coming. What are we going to do? Her blood pressures are super high, 160s over 110s. What are we looking at here? This patient, we're going to have them continuous vital signs. Okay. Typically with these patients, until we get their blood pressure under control, we're monitoring their blood pressure every 15 minutes. We're going to initiate magnesium sulfate therapy, which we're going to talk about that more in detail on the next slide. That is going to help with blood pressure management, but we're also going to be using other medications as well to get that blood pressure under control. That is your number one inner thing that you're doing. You want to get that blood pressure under control immediately, okay? Because the longer that high blood pressure is maintained at that high level, the more damage you're doing to the cells of the placenta, the more damage you're doing to the oxygenation circulation pattern of the fetus, the higher risk your mom is for having a seizure or anything else that's really scary. So we need to get that blood pressure managed right away. So the other things that we can do as nurses is we're going to dim the lights in the room, make the environment as non-stimulating as possible, educate the patient on side effects of medications and the labor process. Like this patient's coming in with an early delivery and they were anticipating having this baby for another month, you know, that's scary. We need to talk to them about it. Magnesium makes you feel like crap. It makes you really hot. It makes you feel like you're out of it a little bit, makes you feel really zoned out and sleepy, just kind of like really heavy and tired. So we need to be telling our patients like, hey, this is what you can expect. So they're not just like, whoa, what just happened to me? You know? We're initiating seizure precautions. So that's patting the side rails, having your suction equipment available, having an O2 mask hooked up and next to the wall, the call button in reach. And that might not be the call button just for the patient. You need to educate the family member too. Like, hey, if this happens, you see her being like acting this way, you need to call us. Have your emergency meds at bedside, insert a Foley or initiate like a toileting plan, most likely a Foley because these patients are on mag, and if they're on magnesium, they cannot get up out of bed. Educate the support person when to call out, and then what is our nursing action during a seizure? What are we doing?
Monitoring for safety, making sure we're not touching them, timing it, seeing the duration of it, the characteristics.
Yes. Yep, definitely. What else? Anybody else got some? Biggest one is your airway, right? Make sure their airway's clear on their side. That suction equipment is available so that if they have like secretions and stuff that are building up during the seizure, you can suction those out. And you're calling your doctors or you're activating rapid response. So as a nurse on the floor, that's one of the first things you should know about is what button do I push for a rapid? What button do I push for a code blue? Okay, so for a seizure, we're activating a rapid response. That'll have your respiratory therapist come to the bedside, other nursing staff come to the bedside. Somebody will get your doctor in there with you so that there's more people in the room. So when we're talking about preeclamptic patients, the go-to treatment for managing blood pressure and managing these patients is magnesium sulfate. You guys are definitely going to want to know a lot about this medication. So it is the medication of choice for preventing seizure activity, which is why we're giving it. It's administered IV. So anytime you have a preeclamptic patient come in and you get a diagnosis of preeclampsia and they tell you that we're starting mag therapy, one of the first things that you should think of is I need to put in another 18 gauge large bore IV. You should have 2 accesses whenever you're giving mag because mag is not compatible with pretty much everything. So you need to have another access in case you have to give a different type of medication. Okay. The initial loading dose of mag is a 4 to 6 gram bolus, which is infused over 15 to 20 minutes. And then there's usually a maintenance dose about 1 to 2 grams an hour. And your dose should maintain a therapeutic serum mag level of 4 to 7. Okay. So you're going to be drawing magnesium like their levels at a specific increment, which your provider will put in the orders for you for that, just to make sure that they're in therapeutic range. Okay. The important thing when you are initially giving that bolus, that is a 2 nurse verifier med. So it's a critical alert medication. You need to have another nurse at the bedside with you when you start this medication. And the primary nurse cannot leave the bedside during the entire initiation of the medication. So whenever they're getting that bolus, the nurse cannot be leaving the room, okay? because every 5 minutes, we're getting a blood pressure and we're doing a focused assessment on our patient. The focused assessment is we're assessing their edema. How's their swelling? We're obviously getting their vital signs. That's your temperature, your heart rate, respirations, your O2 levels, all of it. We're assessing their pain level. We're assessing their neurological status. Are they alert and oriented? ×4 still. What is their status? Are they vomiting? Magnesium will make patients vomit. Okay, that's something you want to chart if they start throwing up. Have your Zofran at the bedside if you are giving magnesium, because most of the time you're going to administer it. You're also going to be assessing their reflexes. Okay, you're going to be assessing their reflexes on their knees and behind their elbows to make sure they don't become hyporeflexic, right? Because magnesium is going to reverse that hyperreflexibility, and it can make them their reflexes not very strong. You're also going to listen to their lung sounds, because we do not want their lungs to be filling up with fluid. We don't want fluid overload. Okay. So these patients on MAG are usually NPO. We're making them NPO because they're on a fluid restriction. And usually the amount of volume that they get in an hour is about 125. So depending on what your maintenance MAG dose is, you're going to be running LR with it. You're going to titrate your LR. So you're giving a 50 mLs an hour of magnesium. You're giving 75 mLs of LR. Okay. So the other thing with MAG is this medication, you want strict eyes and nose, because they're on that fluid restriction, because we're worried about fluid volume overload. We're worried about their lungs getting fluid in them and just overall like fluid hypervolemia. So we need to put a Foley in to monitor their urine output, because as we mentioned in the previous slide, their renal function is going to be decreased with this disease process. Okay. So we need to make sure they're still diuresing and getting out this fluid. If they're not, then a provider might be ordering you other medications to help with their diuresis. Okay. Does anybody know the reversible agent for mag sulfate?
Calcium gluconate.
You got it, calcium gluconate. So that is something you want to have at your bedside, okay? Because if they show signs of mag toxicity, we need to be able to administer that right away, okay? So this is kind of going over all the things that I just said, but it's a high alert med. It causes relaxation of your smooth muscle, which can usually lead to your uterine relaxation. So if a patient's in labor, most of the time we're administering oxytocin along with magnesium to give them more contractions, because their body might respond to the mag by muscle relaxation and uterine relaxation, which might decrease the amount of contractions they have. If a person is on mag, just because they deliver does not mean we stop magnesium. Typically, these patients are observed and on magnesium for 24 to 48 hours after delivery. Okay, and these patients are a 1-to-1. Like if you have a patient that's on magnesium, that is your only patient. Sometimes it's 2-to-1, depending on who it is, what's going on. And I mean, ideally, sometimes the staffing is not that, but what it should be is 1-to-1. We need to know the symptoms of mag toxicity. You guys are definitely going to want to know this. So absent deep tendon reflexes, decreased respiratory rate, and decreased level of consciousness. It's a depressant, so it's going to lower all of that, okay? So like I said too, we want accurate INOs, keep your patient in bed. So we're training our patient, we're doing frequent position changes, vital signs Q15 until that blood pressure is managed. Then you might get an alternative order, but that should be up to your physician and your hospital policy. You're staying at the bedside for the bolus, and you're titrating your fluids. And then obviously, you're monitoring that baby continuously. Okay, this is not a patient we would do intermittent monitoring on. This baby is going to be monitored very, very closely. So moving over towards blood pressure management. So let me see here. Sorry, I moved something. So there's a bunch of different medications that we can give to lower blood pressure pretty quickly before we give magnesium. And it's not uncommon to see providers try one of these medications before they put a patient on mag, just to see if like they can manage it with other medications and it's not necessarily fitting the criteria of preeclampsia with severe features. So we are administering these blood pressures whenever they reach a severe range of over 160 systolic or over 110 diastolic. That is a severe range blood pressure. Okay. If you have two severe range blood pressures back to back in a 15-minute period, that is preeclampsia with severe features, and you need to start magnesium. Okay. That table on page 290 outlines each of these medications that I have listed below here and their dosage, the route of administration, when not to administer them. And this is important information that you guys should know whenever we're talking about meds. So treatment is administered immediately to prevent long-term complications. So the three gold meds that we usually give are hydralazine, labetalol, and nifedipine, which is your Procardia. Procardia is an oral med. So if your patient comes in and has a very high blood pressure and you don't have IV access yet, your provider might say, okay, go ahead and give 10 milligrams of immediate release Procardia to try and just get that blood pressure down to the point that's safe while you're working on getting an IV started. Okay. Labetalol is usually pushed. Like the other day, I actually had a patient on mag on Sunday, and we gave 40 milligrams IV push before we started the magnesium to try and just get that blood pressure to come down a little bit. And that can be administered, I believe it's every 5 minutes you can administer labetalol, but you can't administer over a certain amount. So that should all be outlined for you in your order that you receive from your physician. But labetalol is an IV push med. Same with your hydralazine. The most common ones I see that are given are labetalol and your nifedipine, typically. So moving on to eclampsia. So this is different than preeclampsia. Okay, so you have preeclampsia, then you have eclampsia. Eclampsia is your seizure or coma in a preeclamptic woman. So whenever if your patient were to seize or to enter into a coma, she is eclamptic. She's no longer preeclamptic. Okay. It's typically preceded by symptoms, but this can also occur in women without any hypertension or any other type of symptoms, which is super scary. If they just come in and they start seizing. Symptoms before a seizure is kind of like the same things whenever we're talking about normal seizure disorders. Like the patient might have a persistent occipital headache, blurred vision, photophobia, epigastric pain, and altered mental status. They might have an aura, was another word that we can use. The eclamptic seizure is that tonic-clonic seizure, which I have a picture over here of your tonic-clonic, your tonic phase and your clonic phase. And then after, it's followed by really low blood pressure, disorientation, and amnesia. Like they're not going to really remember that they had a seizure and what they experienced. So what we want to know is what our management as a nurse is going to look like before, during, and after. So before, we're going to obviously assess our patient. We're doing our interview questions if they're having symptoms and if they have any symptoms, if they have a history of seizure disorders. If they do, we're probably going to be initiating like seizure precautions, especially if they're on medication for seizure disorder. During a seizure, we're obviously, like we talked about, we're prioritizing patient safety, ensuring a patent airway, turning patient on the side, moving anything sharp from near the patient. We're calling for help. And then afterwards, we want to stabilize our patient. Okay. We're focusing on airway first for stabilization. Okay. If that means inserting in alternate airway, we need to have anesthesia or a provider at the bedside to be monitoring the patient and doing that. Assess, and if we need to administer oxygen, activate a code or a rapid, suction out secretions. Obviously, if you don't have an IV yet, That's something you need to have. And then we're going to be administering medications to make sure that they don't have another seizure. So administering mag, or increasing the mag dose if they're already on magnesium. And then if another seizure were to occur pretty closely after that first one, we need to administer some IV lorazepam and assess your fetal status. Okay. And then at this point, a doctor might be making the decision of we need to just deliver this baby. And depending on how far into the pregnancy the mom is and what else is going on with her. So does anyone have questions about hypertension, preeclampsia, or eclampsia? Those are really important concepts in labor and delivery. So I want to make sure you guys all feel okay with them before we move on. Okay, cool. So moving on to hyperemesis gravidarum. We talked about this a little bit earlier whenever we were talking about like pregnancy symptoms and things that moms can experience during pregnancy. But this is the most common reason for hospitalization in the first half of pregnancy. And the second most common thing that can happen in pregnancy overall. So hyperemesis gravidarum and just normal nausea and vomiting are very different things. So you guys will need to know the difference between them, okay? So hyperemesis gravidarum, you see a patient with excessive weight loss. They're going to have electrolyte imbalances and dehydration and some nutritional deficiencies because of the way that they're how much they're vomiting. This patient is legitimately going to be vomiting and nauseous 24/7, and nothing is going to be able to really help it. They're barely going to be able to take in any water or any food. They might get to the point where they're like vomiting up like blood because they're irritating their esophagus so much because they're puking so profusely, like literally all the time. And for treatment wise, they need antiemetics and some IV fluids. They're measuring INOs and then oral hygiene, and we're going to educate them on diet. So this patient is at a high risk for dehydration because of the amount that they're vomiting. Okay, so they definitely need to go into the ER or to the hospital and get an IV so that they can make sure that their hydration status is adequate. So things that we want to tell them is avoid an empty stomach. They should be eating small, frequent meals of dry, bland, and high protein food. Okay. Protein should be taken in after sweets. Cold is better than warm. And then they should be alternating between fluids and solids. Okay. This is going to help them at least keep some things down. But like we were mentioning, like if it's starting to get to the point where they can't keep anything down, they need to go and seek medical attention. So I stole this fancy little diagram from Professor McBride. I love this. This kind of shows you the things that are normal for nausea and vomiting in pregnancy, and then what crosses the line into hyperemesis gravidarum. So the things they share, some is you might have a distaste of certain foods. Food odor can trigger the nausea, and then nausea at any time of day. But this hyperemesis gravidarum is this nausea with severe vomiting, persistent vomiting that's causing weight loss, nutritional deficiencies, electrolyte imbalances, ketonuria, and then it can cause severe dehydration. Okay. We're going to be moving on here to some bleeding and pregnancy things. So, a miscarriage or spontaneous abortion before 20 weeks is something that we want to talk about. This is defined as an early loss, which is typically before 12 weeks. It can also be categorized into late loss, which is 12 to 20 weeks. And it can be split up into, how many is that, 1, 2, 6 different groups. So you can have a threatened abortion, inevitable, incomplete, complete, missed, and aseptic. These types of miscarriages can usually, some will happen on their own spontaneously. Others might need to have medical intervention or surgical management once it's confirmed, depending on how far along the pregnancy is or if mom is having any adverse signs and symptoms. The other thing we'll talk about is cervical insufficiency and a procedure called a cerclage, which I have a picture on the next slide that will kind of help us with that. But typically for like an early miscarriage, that is when like a mom will have like some bleeding within the first 12 weeks of pregnancy, intense cramping. She might pass the fetus on her own without any type of intervention, and that would just be like a very, very heavy period. She would have to go to the hospital to make sure that they do a scan to make sure all the products of conception have left the uterus so that she's not at increased risk for sepsis or bleeding disorders. Late miscarriages are caused oftentimes by cervical insufficiency. Okay. And cervical insufficiency is usually passive and painless dilation of the cervix, which lead to recurrent preterm births. Okay. Cervical insufficiency is one of those things that providers have a really hard time diagnosing in pregnant women. One of the things that they may evaluate a mom for would be a very shortened cervix. Moms that have short cervixes will sometimes have the cervical insufficiency where they're having preterm deliveries. But a cerclage is the number one go-to for treating cervical insufficiency. And I'll describe that more to you guys when I have the picture to kind of talk alongside with, because it makes a little bit more sense when you're looking at the picture for it. Okay. Whenever we talk about medical or surgical management, so medical management could be like if a mom comes in and she's 8 weeks pregnant, there's been no, like she either has a blighted ovum or there's no heartbeat, or it could be an ectopic or anything like that. We're going to need to do some medication to either help the pregnancy pass or dissolve the pregnancy if it's an ectopic. So the number one thing that providers will usually prescribe to help pass a miscarriage is called Cytotec, which is a medication we also give postpartum. And that can be given to women to help pass the products of conception and help move the process along if that's something that she is wanting. Surgical management is going to be your dilation and curettage, that D&C procedure, where the provider will go in and medically remove everything from the uterus. Okay. And usually they do D&Cs if it's a little bit later in pregnancy and if there's more tissue development of the fetus. Okay. The other thing I have that we would need to talk about are ectopic pregnancies. This occurs whenever there's a fertilized ovum implanted outside of this cervix or outside of the uterus. Medical or surgical intervention is needed. So the go-to medication for an ectopic pregnancy is a medication called methotrexate. Methotrexate will terminate the cells developing, which causes the pregnancy to be absorbed within the next 4 to 6 weeks. Okay. Otherwise, if the ectopic pregnancy has grown to a pretty substantial size and they didn't catch it right away, the mom is going to need surgical intervention. And typically what that means is they need to remove whatever tube or whatever fallopian tube the pregnancy is developing in. Okay. Most of the time it's just the one tube, but sometimes in really severe cases it is both tubes, if not a hysterectomy. So that's why, and especially like if a tube bursts, right? Like the ectopic pregnancy is developing in that fallopian tube and it's grown to the point that it has burst the tube. That's an emergency. That mom is bleeding pretty severely and has to be rushed back for surgery. And she's at a higher risk of losing both tubes if not having a hysterectomy performed. And then the last thing here is a molar pregnancy, which is a benign growth of placental cells. And it causes like just a bunch of grape-like clusters. And this we need to do is D&C on. And I have a couple pictures here on this next slide. So this picture here on the left, this big one here, over here, I don't know if you guys can see my arrow. This is a cerclage. Okay, so what they do is they go in, the OB provider will go in and sew the cervix, the opening of the cervix closed. And this is usually for that cervical insufficiency to prevent the cervix from opening and preventing preterm labor. Okay. there's different kinds of cerclages. You guys do not need to know the difference of the cerclage. Just know that what it is and that it's used for cervical insufficiency and preventing preterm delivery. Okay. The next, the one over here in the top right-hand corner is a picture of a ectopic pregnancy where that fertilized ovum is adhered and attaching to the fallopian tube. Okay. And then down here is that picture of that like grape-like structure, the molar pregnancy, which would just be, we would need to do a DNC for that. Okay. This here has a bunch of different pictures on like missed, threatened, inevitable, incomplete, and complete abortions. Your book also goes into a little bit more detail with the differences in all of those and what moms will experience, like signs and symptoms. So just go ahead and review those on your own time. We're going to talk now about late pregnancy bleeding. And two of the biggest causes for late pregnancy bleeding are placenta previa and placenta abruption. So a placenta previa is when your placenta is implanted in the lower uterine segment so that it completely covers or partially covers that cervical opening. So you have your cervix, you have the placenta, then you have your baby. And that's not good because you can't deliver a placenta before you deliver a baby, right? So this is an OB emergency. This is something we're going to be treating and monitoring very closely. So whenever we're talking about maternal and fetal outcomes, the main complication is hemorrhage. So obviously with any major hemorrhage in postpartum period, you run the risk of the mom needing a hysterectomy. That is in the worst case scenario. Okay, you've done everything you can to try and stop this hemorrhage. Nothing else is working. We need to do a hysterectomy. Okay, these patients that have a placenta previa cannot deliver vaginally. We have to do C-sections on them. Okay, because you can't deliver a placenta first, and that's what the presenting part is. So we're not going to deliver vaginally. We worry about preterm birth and IUGR in these patients, mostly because we're taking patients with placenta previas and delivering them earlier. We're not going to usually allow them to go full term, okay, just because we don't want them to go into labor. If you have a patient who has a history of a placenta previa or who has a placenta previa in that pregnancy, you do not want to check their cervix. Why? Why would you not want to check their cervix if their placenta is in front?
Can't you rupture their placenta?
Yeah, you irritate that cervix, you run the risk of poking through that placenta, irritating that, causing bleeds. With these patients too, anytime you're checking a cervix, you run the risk of irritating the cervix and initiating labor. We don't want to do that. Okay, so with placenta previa patients, usually if they're doing an exam, it's going to be a speculum exam that the provider is going to look at the cervix to see if it's open. Okay. Clinical manifestations of this would be painless, bright red vaginal bleeding during the second or third trimester. Management is you're going to educate the patient when to come to the hospital. Anytime a patient with a placenta previa has bleeding, they need to come in for an evaluation. Okay. And what's confusing about that is patients that have previas typically have spotting and typically do have bleeding during their pregnancies. So we need to be educating them on, okay, if you're filling up a pad, if you're bleeding pretty consistently, it's dripping into the toilet, you need to come in and be seen. No vaginal or rectal exams, close observation. And like I said, this is an OB emergency. We need to be delivering these babies if the mom's coming in labor. Okay. Placental abruption is the premature separation of the placenta with detachment of part or all of the normally implanted placenta from the uterus. And this is happening before labor has started usually, or it can happen during labor depending on what happens. And this is a OB emergency and it warrants a stat C-section. Okay. Biggest risk of a placental abruption is maternal hypertension. That is definitely something you guys are going to want to know. The other ones are your cocaine, tobacco use, any motor vehicle accidents, domestic violence, any type of trauma to the abdomen, right, can cause an abruption. Your manifestations, this mom's going to be bleeding pretty heavily. She's going to have intense abdominal pain. Like she is not going to even be able to sit still. And you know it's not going to be contraction pain because it doesn't go away. Contractions come and go, right? This kind of pain is just consistent, like a stabbing pain right in their belly. they're going to have that uterine tenderness. And their belly is going to be super firm because it's filling up with blood because the placenta is abrupting. Prognosis would be the prognosis depends on the extent of the abruption, the amount of blood loss, and length of time. Okay, so if you have a mom that you're monitoring already in labor and you can tell that she's abrupting and you get her right back for a C-section, odds are mom and baby are both going to be fine. If you have a mom that comes in just out of nowhere willy-nilly on the street and she's been bleeding for a couple hours and she didn't really know what the source was, but now her pain hurts, her belly has been hurting really bad for the last 2 hours, like you might need to be calling your NICU team for this delivery and just anticipating some more complications. If the mom is 20 to 34 weeks, we're going to attempt to stop bleeding and keep the mom under observation in the hospital. But if they're near term, we're going to just deliver this baby. Cord insertion variations can also sometimes cause some bleeding, but not typically. So the biggest ones we see are vasa previa, a velamentous insertion, and a secondary placenta. So a vasa previa is when the fetal vessels lie over the cervical os. So the vessels are implanted into the fetal membrane rather than into the placenta. And then usually these vessels are protected only by the membrane, not by Wharton's jelly. So they're at risk for rupture or compression. Okay. It's just an alternate way that the placenta develops. SROM, so spontaneous rupture of membranes or traction on the cord can rupture fetal vessels. And like I said, they're implanted in the membrane instead of the placenta, and you risk for rupture or compression of those vessels, which can cause some bleeding. A velamentous cord insertion is a variation of a vasa previa. This is when cord vessels begin to branch at the membranes and then course into the placenta. And I'll show you different pictures of each one of these because it's easier to see them a little bit. So let me see. Yeah, so here on the right, you have the velamentous cord insertion versus what a normal cord insertion is going to look like. Okay. And then your the last one here is when occurs when the placenta is divided into 2 or more lobes rather than remaining as a single mass. Okay, so they've got like 2 different sections on the placenta. Okay, so DIC is an acquired syndrome characterized by intravascular activation of coagulation, which becomes widespread rather than localized. So it results in excessive clot formation and hemorrhage. This is never really a primary diagnosis. Instead, it usually results from some major event that causes that hypercoagulation. In this case, the most common cause of DIC in your laboring moms is a placental abruption. Okay, that's who we're really concerned about with this. Management for this is we're correcting the underlying cause. Okay, we're going to be giving volume and expanders, so albumin, red blood cells, plasma, rapid replacement of blood products, clotting factors. We want to optimize oxygenation, achieve the normal body temperature, maintain hemodynamic regulation, and continually reassess labs and vital signs. We are with these patients. We are constantly monitoring them. Okay, these patients are in the ICU usually. Okay, for treatment. But the biggest thing we need to know about this is we're correcting the underlying cause. Okay, so if this patient's abrupting, we need to get in there and do surgery and fix the bleed, prevent them from hemorrhaging anymore, and then be giving them that the fluid replacement as needed. Okay. So some infections that are required during pregnancy, obviously we talked a little bit about STDs and STIs already, but STIs may contribute to infertility or sterility. And it's normal to test every patient and their prenatal care appointments for all STDs and STIs. UTIs and other like type of tract infections, renal infections are listed here. So like asymptomatic bacteria would be the persistent presence of bacteria in the urinary tract, and it's often asymptomatic. The patients are asymptomatic with this. And if it's left untreated, it can develop into acute pyelonephritis, which is a big deal. So that's why at every prenatal appointment, they're getting a urine sample from moms to make sure there's no bacteria growing in the urinary tract. Okay. Cystitis is your bladder infection. Symptoms of that would be dysuria, urgency, and frequency. We want to treat this, obviously. Most of the time, they treat it with antibiotics as long as it's safe to be used. The antibiotics are safe in use during pregnancy. And then pyelonephritis, which is your renal infection, which is the most serious. This is the leading cause of septic shock in pregnancy. So we want to have early recognition of this, educate our patients on signs and symptoms, and treat it very quickly. Group B strep is something that we get on every single patient, pregnant patient. We usually collect it at 35 weeks gestation. It's a swab. So we take a Q-tip and we swab the vaginal opening. We drag the Q-tip down to the rectum and do like a little swab on the rectum. And that is how we test for group B strep. Group B strep is a normal bacteria that already lives in the vaginal canal, but it's very harmful to babies. It can cause like neurological and eye condition, like eye problems. So we want to make sure that if mom tests positive for group B strep, she's getting antibiotics during labor, okay, to minimize the amount of that bacteria that's present in the vaginal canal as the baby is coming down through it. Oh, one other thing I want to mention about group B strep. Oops. If your patient is unknown, like we don't know what the result is, we're going to be treating them as if they're positive. So you'd give them antibiotic treatment. The go-to treatment for group B strep is penicillin. All right. Some surgeries that could potentially need to happen during pregnancy is if the patient has appendicitis and needs their appendix removed. This is the most common non-obstetric surgical emergency during pregnancy. That is characterized by that right lower quadrant pain, fever, chills, hypersensitivity in that area. An appendectomy is recommended, even if it's not evident. Like if it's slowly developing and they're not really at the point where it's like super bad, they still might operate and remove that appendix. And then cholelithiasis and cholecystitis would be like if the mom has gallstones or gallbladder inflammation. This is characterized by that epigastric or right upper quadrant pain, which may radiate a little bit. I have that chart here that kind of shows you the disease process of both and where they're located. Obviously, with any pregnant lady, we're really going to be taking into consideration her underlying medical conditions and her medical history and just how bad her disease process is before we're just operating on her, because anytime a mom is exposed to anesthetic in her pregnancy, it runs the risk of harming the fetus with general anesthetic specifically. So we just need to really take that into consideration and decide what's indicated and what's contraindicated. So trauma during pregnancy is another big thing whenever we're talking about any issues during the pregnancy. It's common, but often underreported. The most common is going to be your motor vehicle accidents and falls. So we're worried about fetal morbidity and maternal mortality. So things that we're worried about whenever we're looking at trauma would be your miscarriage, preterm birth, preterm premature rupture of membranes, uterine rupture, and which these can all lead to cesarean birth, placental abruption, and sometimes stillbirth. I listed here the mechanisms of trauma, which are your blunt, penetrating, and thoracic. So your blunt is typically from a motor vehicle accident, but it can be from domestic partner violence or any falls, which is just when there's that trauma directly to the abdomen. Penetrating would be like a bullet or a stab wound. And then thoracic would be pulmonary contusions as a result of blood trauma. So we're talking like a pneumo. Okay. Maternal adaptations related to trauma. There's a good table on page 315 for you guys to reference when it comes to this stuff. You're looking at like the optimal care for the patient after trauma depends on understanding the pathophysiology of pregnancy itself. So moms have an increased cardiac output due to decreased arterial pressure and systemic vascular resistance. Okay, so the way that their bodies respond in trauma is going to be different than the way that anybody who's not pregnant would respond to trauma. Okay, so whenever you're also assessing your baby, your electronic fetal monitoring may reflect maternal compromise. So if your mom is having some difficulty breathing, they're having low blood pressure because they're bleeding profusely, the baby is not going to look good on the monitor, right? You're going to have your infant looking a little bit bad. So if your mom comes in, if you have a mom that comes in who said, I was in a car accident or I fell down the stairs or whatever, you need to monitor that baby for a minimum of 4 hours. Usually they keep these patients overnight and monitor them for 24. The baby also may on the strip show early signs of placental abruption, depending on what's going on with that tracing. And unfortunately, we're ending our PowerPoint on not a very fun topic, but resuscitation of a pregnant woman. So causes of maternal cardiac arrest include hemorrhaging, heart failure, amniotic fluid embolism, sepsis, aspiration pneumonia. We want to focus on maternal resuscitation before we focus on what we're going to do about baby. Okay, so you want to start your compressions immediately if a mom who is pregnant is coding. Okay, we're not trying to put the baby on the monitor first, we're immediately starting compressions. Whenever you're doing compressions on a mom, you have to have left lateral uterine displacement. She can't just be laying on her back. Okay, so you need to put a wedge or a blanket or a pillow or something underneath her side so that she's tilted onto her left side when you're doing compressions on her. Whenever we're thinking about defibrillating a patient who's pregnant, we place the paddles a little bit differently. So we place the paddles one rib interspace higher than usual. And that's just because everything is pushed up because of the baby, right? So we're going to be moving those pads a little bit. So perimortem cesarean birth. So whenever a mom is having a cardiac arrest, that baby we need to be delivering within 5 minutes, because if mom's not getting blood flow and not having circulation throughout her body without compressions, baby definitely is not, because your placenta in that case is not considered a vital organ, right? So all of mom's blood and all of her attention is being shunted to her own vital organs. So the placenta and baby are not getting any blood or oxygen flow. So we need to do 5 minute cesarean birth immediately if mom is coding. Okay. Sometimes too, delivering that infant improves both fetal and maternal chances of survival. So getting that baby delivered as you're still doing compressions, as you're doing all the things to try and resuscitate mom, could in turn help both of their chances of survival as well. Okay, so yeah, that's not a very fun slide to end on, but that is the last slide I have for you guys. So let me see here. I'm going to stop my share. Okay, so does anybody have any questions over any of that stuff that we just covered, or any of the assignments or anything that are coming up, or anything else about class really? Okay, well, you guys did awesome today. That's a lot of information, a lot of stuff thrown at you all at one time, but you guys, for the most part, all stayed awake, so thank you. Like I said, this week you guys have your OB Math 2 calculations and your preeclampsia sim chart assignment. And then next week we will have another quiz at the beginning of class, so please make sure you're here on time. And we'll also have next week the placenta previa sim chart assignment and your NCLEX questions. Whenever you do those NCLEX questions, make sure you read really thoroughly, like the prompt at the top, because it'll tell you exactly what subsections of the questions you need to do. Okay, and that's what we're looking for. So we didn't really have too many problems with the first assignment. You guys all did relatively pretty good, so I'm not too worried about it, but don't hesitate to reach out and ask. And if I sent you an email about meeting with me, go ahead and respond so we can set up a time. Usually I plan like 30 minutes to an hour depending on how much you guys want to review. Okay. But if nobody has any other questions, I think we'll be good to end class here. Okay.
Thank you.
Yeah.
Thank you,
Have a good
Professor
day.
Young.
Have a good day, everyone.
Thank you, you too. Okay, you want to practice? Hold on.
I wonder if Haley knows class is over. You can move her to your waiting room.
Cool.
Great. That was good.